Hello class, it's me, Dr. Jenkins. I couldn't find an introductory review of acute kidney injury that I thought was appropriate for first year medical students, so decided to make my own. Hopefully this turns out okay. Here are the learning objectives that we're going to cover in this talk. So first let's start with some definitions. An acute kidney injury is a sudden and often reversible reduction in kidney function. And so that can be manifest as an increase in serum creatinine or as a reduction in urine output. And so we'll use different terms to describe that reduction in urine output. Oliguria means that the patient is urinating less than 500 milliliters of urine output per day. But really, people say you're oliguric, you're making a little bit of urine. Whereas anuria typically means they're not making any urine, although technically the definition is less than 50 mLs of urine output per day. But when we say a patient is anuric, it's because they're not urinating. And there's no universally agreed upon definition for acute kidney injury. There's a few different versions out there. This is from the Kidney Disease Improving Global Outcomes, or KDIGO, guidelines. They classify acute kidney injuries into 3 stages. And we're not going to ask you to memorize the stages, and on your clerkships, no one's going to ask you what stage of acute kidney injury the patient has. I think these were mostly developed for research purposes, but probably the number you should know from this chart is in stage 1 acute kidney injury, the creatinine is going to go up by at least 0.3 milligrams per deciliter. And that's probably the definition that gets used the most in the clinical setting, because it's pretty easy to say, oh, their creatinine went from 1 to 1.4. Okay, this is an acute kidney injury. So that might be useful, but it's also important just to recognize that there's the creatinine definitions, and then there's also urine output. So if you see a patient's urine output, say you're in the intensive care unit and you're monitoring urine output pretty closely, if you see urine output stop, you don't need a serum creatinine to diagnose that person with an acute kidney injury. So it's helpful to think about acute kidney injury in these 3 broad categories. So pre-renal injury, intrarenal injury, and a post-renal injury. And so pre-renal injury is dealing usually with problems of blood flow or perfusion, but the problem is before the kidney, which is why it's pre-renal. And then intrarenal, the problem is in the kidney itself, and we'll talk about a variety of causes of that. And then post-renal, as shown here, is pointing at the ureter. Post-renal is typically distal to the kidney, so the urine has now left the kidney and it's being obstructed somewhere, and so a post-renal cause is typically going to be obstruction. So pre-renal injury, you'll often see it referred to as pre-renal azotemia. And azotemia basically just means that there's an accumulation of nitrogenous waste in the blood. So urea is the main nitrogenous waste we're talking about. So you'll see an elevation in the blood urea nitrogen on the patient's basic metabolic panel. And this pre-renal injury is the most common cause of a community-acquired acute kidney injury. So people that are coming into the ER and have a bump in their creatinine, it's usually going to be a pre-renal etiology. And pre-renal injuries are caused by inadequate perfusion of the kidneys. And the most common reason that might happen is if they have intravascular volume depletion. We say they're hypovolemic. And this could happen if they've had a lot of volume losses. So say they've been up all night puking, or they've had diarrhea, or if they're bleeding to death, or say they got way too much loop diuretics and they've lost a lot of volume in their urine. So if you dry someone out too much, then you'll see a bump in their creatinine, and so that would be a pre-renal injury. Another type of inadequate perfusion comes from having a decreased effective circulating volume, and this is sometimes also called the decreased effective arterial blood volume. But basically what this is describing is the kidneys are not sensing that they're getting enough blood flow. Even though the patient might have plenty of blood volume, the kidneys for some reason are not sensing that they're getting enough. And so a very classic example of that would be congestive heart failure, especially if someone has low cardiac output. If they don't have good forward flow and stroke volume, then the kidneys are going to feel like they're not getting enough blood flow from the heart. And so you might see an acute kidney injury develop because of that. Other causes of decreased effective circulating volume would be cirrhosis, which is liver disease, or nephrotic syndrome, which is a type of glomerular kidney disease that we'll talk more about, and then sepsis. Sepsis, is a response to infection. You get vasodilation, and sometimes that means reduced blood flow to the kidneys. And then another special case of prerenal injury is related to impaired autoregulation of renal blood flow, and this can be exacerbated by certain medications like NSAIDs, ACE inhibitors, and angiotensin receptor blockers. So here's a little graphic describing that. So you'll see on the graphic that you have the afferent glomerular arteriole bringing blood into the glomerulus to be filtered at the glomerulus, and then you have blood exiting through the efferent glomerular arteriole. And blood flow into the afferent glomerulus is really controlled by prostaglandins. So prostaglandins will dilate that afferent arteriole, and if a patient is taking a medication like a nonsteroidal anti-inflammatory like ibuprofen, that's going to inhibit production of prostaglandins by cyclooxygenase. And so NSAIDs actually cause constriction of the afferent arteriole, which is going to decrease renal plasma flow and decrease GFR. Now, that doesn't mean that NSAIDs are inherently bad, but if you have a patient who's already volume depleted because of, they got a bad stomach bug, and then they take NSAIDs on top of that, it's like 2 hits to the kidney, and the kidney would normally, dilate that afferent arteriole when it's feeling dry to increase blood flow to itself. But if you've taken ibuprofen, now you've inhibited the kidney's ability to do that. So that can precipitate an acute kidney injury. The efferent arteriole is regulated by angiotensin II. So angiotensin II will constrict the efferent arteriole in order to increase glomerular filtration pressure. And so what happens with someone who's taking an angiotensin receptor blocker or an angiotensin converting enzyme inhibitor, those people are no longer going to be able to constrict their efferent arteriole when the kidney is getting low renal plasma flow, and so they will also potentially develop an acute kidney injury. Now, the worst is if you're on both an ACE inhibitor and an NSAID, because now you've basically messed up the kidney's ability to regulate blood flow on both limbs. So pre-renal kidney injuries are usually made, the diagnosis is usually a clinical diagnosis, and so there are going to be clues in the history and the physical exam. So the patient tells you that, I haven't been eating or drinking very much, or I've been vomiting all night. And then on exam, they're going to have signs of low volume status, right? So dry mucous membranes, a low jugular venous pulsation, maybe they have increased skin turgor. And so those are some findings that might suggest that the patient is dry. Now, if you were to look at a urinalysis or urine microscopy, you're not going to see very much. There won't be any blood cells, there won't be any protein from a pre-renal injury. You might see like hyaline casts, which are nonspecific, but really those are not going to be super helpful in a pre-renal injury. But if you were to look at the specific gravity on the urinalysis, which is a measure of solute concentration, you would expect it to be pretty high, like over 1020, because the urine is going to be more concentrated. And then if you look at the urinosms, again, you expect those to be high because the urine will be concentrated. So you think about a kidney that's sensing poor perfusion, you're going to get release of renin, angiotensin, and aldosterone with antidiuretic hormone. And the antidiuretic hormone is going to help reabsorb more water back into circulation. And so that's going to make your urine more concentrated. So urinosms will go up. And so we don't measure antidiuretic hormone clinically, but if you check urinosm, that's a pretty good surrogate for antidiuretic hormone. And likewise, because aldosterone is very active, you're also going to see very low levels of sodium in the urine because the kidneys are going to hold on to all the urine that they can. And so if you check a urine sodium in someone with a prerenal injury, you'd expect it to be pretty low, like less than 20. And again, we don't typically measure aldosterone in the setting of kidney injury, but that urine sodium is a good surrogate for aldosterone activity. And then there's something called the fractional excretion of sodium and the fractional excretion of urea, which are also going to be low in prerenal injury. We'll talk more about those on the next slides. So the fractional excretion of sodium is based on the principle that when kidneys are getting low perfusion and RAS is activated, you're going to hold on to all the sodium that you can. So of all the filtered sodium, you're going to excrete a very small amount of that. You're going to try to reabsorb all the sodium that's possible. And so the calculation or the equation to do this is sodium in the urine times creatinine in the serum divided by creatinine in the urine times sodium in the serum, times that by 100. And if that's less than 1%, then it suggests that the kidneys are holding on to all the sodium that they can. Now, what if the patient is taking a medication that leads to sodium excretion? So, you've got a patient on a loop diuretic that's leading to more sodium being lost in the urine, or a thiazide diuretic, which also leads to that. They could have an acute kidney injury, but their urine sodium is going to be elevated, and so you can't trust that value. Well, it turns out that when you activate RAS, you're also going to get more reabsorption of urea. So your blood urea nitrogen is going to be elevated, usually in prerenal injuries. And so you can do a similar calculation as the fractional excretion of sodium, but it's the fractional excretion of urea. So a very similar formula. And if your fractional excretion of urea is less than 35%, then it suggests that the kidneys are holding on to urea and that they're in a prerenal state. You'll also see the BUN to creatinine ratio talked about. It's in first aid. You might see it on step 1. Maybe not super clinically useful, but you would expect, because of that increased reabsorption of BUN, your BUN should be more elevated probably than your creatinine is. And these rules don't always hold, but that's one other clinical clue that they might be having a prerenal injury. So how do we manage a prerenal acute kidney injury? The main goal is to restore perfusion to the kidneys. And so obviously if the patient's dry, we want to give them fluids. Typically we do that with isotonic fluids like normal saline and lactated ringers. If the patient has liver disease like cirrhosis, we'll often give them albumin instead of isotonic fluids. And then if they're hypotensive, you're also going to give them isotonic fluids. And if their blood pressure doesn't get better, then we could start vasopressors like norepinephrine or epinephrine to keep their blood pressure high to improve perfusion to the kidneys. Now, sometimes the patient is actually hypervolemic, so they have too much salt water, too much plasma volume, like in congestive heart failure. And so to actually improve kidney perfusion, you give diuretics. And that's because renal perfusion pressure is equal to your mean arterial pressure minus the right atrial pressure. And if the right atrial pressure gets too high because the patient has been holding on to way too much salt water, then the kidneys are actually going to have inadequate perfusion pressure. And so if we can diurese them with some, say, loop diuretics, get their right atrial pressure lower, then we can actually improve perfusion to the kidneys and improve their kidney injury. And then if the patient has congestive heart failure and low cardiac output, those are the patients that we give inotropes to, like dobutamine, which is a beta-1 agonist. We're going to make the heart pump stronger to get a bigger stroke volume to improve perfusion to the kidneys. All right, next we'll talk about intrarenal injuries. So you can kind of divide these up into tubular, glomerular, interstitial, and vascular type injuries, but this is where the problem is in the kidney itself. Probably the most common cause of an intrarenal kidney injury is acute tubular necrosis or acute tubular injury. It's often cited as the most common cause of hospital-acquired acute kidney injury. So patients who develop kidney injuries while hospitalized, it's often going to be acute tubular necrosis. And this is due to prolonged or severe hypoperfusion leading to tubular cell ischemia. So sometimes the person comes in with a pre-renal injury and they don't get their perfusion to the kidneys restored, and so the kidney cells get ischemic and they can die or be injured. Oftentimes it's preceded by hypotension, so someone comes in cardiogenic shock or septic shock, really low blood pressures, not getting good blood flow to the kidneys. They take an ischemic hit, and this can cause acute tubular necrosis. So those are the perfusion type injuries. You can also have direct toxic injuries to the tubular cells, so certain medications like vancomycin, aminoglycosides, and there's other antibiotics out there that can be directly toxic to the kidney tubules. And then interesting, myoglobin, which is a pigment, a heme pigment in the muscles. If you have muscle cell breakdown and you release too much myoglobin into the bloodstream, that myoglobin is actually toxic to kidney tubules, so that can cause acute tubular injury. Same thing with hemoglobin. If you have intravascular hemolysis and you have excess hemoglobin, free hemoglobin floating around in the blood, that is also toxic to the tubules. And then certain chemotherapies, especially platinum-based chemotherapies, can cause this type of injury. So typically in acute tubular necrosis, your urinalysis will be bland in the sense that there's not going to be any hematuria, so no dysmorphic red blood cells, and there might be some proteinuria on the dipstick, but it's usually a non-albumin proteinuria, so the dipstick might actually be negative. If you do urine microscopy, you're going to see a lot of muddy brown casts, and these are made from dead, sloughed off tubule cells. So because of this ischemic injury, the cells have died, they've sloughed off into the urine, and they appear as these muddy brown casts. So because the tubules are damaged, they can't concentrate urine or hold on to sodium like they normally would. And so there's different clues in the urine studies that can tell you that this could be an acute tubular injury. So if the urine specific gravity is the same as glomerular filtrate, which is 1010, that tells you that the kidneys aren't concentrating or diluting, right? It's just whatever goes into the glomerular filtrate, that's what's coming out. And so your specific gravity of 1010 can be a clue that this is an acute tubular injury. Also, if you look at the urine osmolality, it's going to be less than 350, and that's because your serum osm is about 300. And again, that glomerular filtrate is basically just coming straight from your serum, and so you're going to have about the same osmolality as what your serum is in the urine because you're not concentrating or diluting. Likewise, you're not holding on to sodium, and so you're going to see a lot of sodium, usually over 40 milliequivalents per liter in the urine. And then, unlike a pre-renal injury, which has a fractional excretion of sodium less than 1%, acute tubular injury is usually going to have Fe or a FeNA over 1% and usually more than 2%. And then the correlate to that you'll often see, like in first aid, is that the BUN to creatinine ratio is going to be less than 15. So this slide is just showing you a bunch of muddy brown casts, right? So you see that these are basically ischemic tubule cells that have been sloughed off in the urine, and these are pretty much diagnostic for acute tubular necrosis. If you see muddy brown casts on a quiz or on step 1, you pretty much know it's acute tubular necrosis. So with acute tubular injury, there's kind of 4 different phases. There's that initiation phase, which is the initial hit, and the hope is that if you can try to improve perfusion to the kidney quickly enough, this may be reversible. But once the damage is done, there's not a lot you can do, and that's when you enter this maintenance phase. And that could be pretty variable how long it is. It could be 1 week, 3 weeks, 2 months, where there's not much you can do. You're just waiting to see if the kidneys are going to get better. And so the patient might make a little bit of urine, and the more they make, the better they're going to do in this phase. If they're anuric, then they're probably heading for trouble pretty quickly. And when we have patients who develop this acute tubular injury, and I kind of tell them, like, your kidneys have basically gone to sleep, and we're just going to wait and see if they wake up. and you kind of just have to support them through that phase. And so you may need to do dialysis. Like if they stop urinating, you're probably going to end up doing dialysis while you're waiting. And this is kind of where you don't know for sure if they're going to get better. If they do get better, typically the next phase then is this diuretic phase where, because the tubules are still damaged and recovering, you're not concentrating urine very well. So you're actually going to make lots of urine and have polyuria. So we call this the diuretic phase, where they just dump water. And they're also dumping a lot of electrolytes. So they might actually get low on some of their electrolytes like potassium. And so typically once they hit this phase, you have to do labs fairly regularly to monitor those electrolytes. And then once they get past that diuretic phase, we're in that recovery phase, which can take days to months to really go back to normal. And you may never get back to what your baseline renal function is, but many patients do get pretty close. So your next type of intrarenal injury are your glomerular injuries, and this is typically referring to like a glomerulonephritis. And there's a few different flavors of those we'll talk more about, but there's the rapidly progressive glomerulonephritis where your creatinine can rise quite quickly, and that's usually going to be from an autoimmune condition like lupus or ANCA vasculitis or like a Goodpasture syndrome. And then there's also glomerulonephritis associated with infections like endocarditis, and staph or strep infections can cause an infection-associated glomerulonephritis. So these are the patients that do not have a bland urinalysis. So when you look at their dipstick, they're going to have blood and they're going to have protein. And when you do a microscopy, you're going to see dysmorphic red cells or red cell casts. And that's a sign that there's something really bad going on in the kidney. And these are often the folks who end up getting a kidney biopsy very quickly. Another type of intrarenal injury is interstitial injury, and the most common one there is acute interstitial nephritis. And so the most common cause of this would be medications, especially beta-lactam antibiotics like penicillins and cephalosporins, but it can also be caused by diuretics and NSAIDs and proton pump inhibitors, and then these newer chemotherapies, these checkpoint inhibitors like pembrolizumab that cause autoimmune disease, they can cause interstitial nephritis. And then you have other autoimmune conditions like sarcoid lupus and Sjogren that can manifest with interstitial nephritis. And in these people, when you do urine studies, your urinalysis is going to show evidence of white cells. So maybe they have a positive leukocyte esterase, and they're going to have a mild proteinuria, usually a tubular proteinuria, so it doesn't have albumin, so it may not be positive on the dipstick. When you do urine microscopy, you might see white cells and white cell casts, and your complete blood count may show that there's an increase in eosinophils. And historically, it was taught that acute interstitial nephritis is going to cause an elevation in urine eosinophils, but that really hasn't been borne out by the data. But you may see an increase in eosinophils in the blood. All right, the last big category of acute kidney injuries are the postrenal injuries, and these really are caused by obstruction. And that can be at the level of the bladder outlet. So say the person has a really large prostate, either benign prostatic hypertrophy, or they could have like prostate cancer, so no urine is getting out at the outlet. You can also have outlet obstruction from blood clots. Say they have a bladder cancer that's bleeding. Those blood clots can obstruct the urethra and cause a kidney injury, or they might have a urethral stricture or like nerve damage that leads to a bladder that doesn't contract, and so the urine can't get out. And that same thing can be caused with anticholinergic medications. And then you could have ureteral obstruction either by a cancer or other pelvic masses or bulky lymphadenopathy. Kidney stones can cause obstruction. Typically, they're not going to cause a kidney injury unless the patient has also got something else going on, or they only have one kidney. Because if you obstruct the ureter on one side, the other side's usually fine. But you could have kidney stones on both sides, or perhaps they're coming in a little volume depleted, and then they've been vomiting because they got this kidney stone pain. And so maybe they have a pre-renal injury plus a kidney stone causing a post-renal injury. And then there's this entity called retroperitoneal fibrosis, which can also cause obstruction in both ureters. So typically a post-renal injury is going to be diagnosed with imaging. The urine tests and the serum tests aren't super great for differentiating post-renal from the other causes, but imaging is. And so you could start with a pretty cheap test, a bladder scan, where you're basically just measuring how much urine is in the bladder. And if you're seeing a lot in there, like sometimes you'll see 1 or 2 liters of urine in the bladder, that person is definitely obstructed. Get a urinary catheter in there and measure the exact volume of urine that comes out. But sometimes the obstruction is more proximal, right, up in the ureters, and so a renal ultrasound would be more useful in that scenario. So you'll see on the top picture the renal ultrasound showing what a healthy kidney looks like. You have the cortex and the medulla, and you don't see a lot of liquid in there. Whereas in the bottom picture, you have basically replacement of all that healthy tissue with urine, with liquid there, because there's so much pressure going backwards from the obstruction. And then also other imaging modalities like CT abdomen or MRI are also very good at picking up hydronephrosis. But a renal ultrasound is something that you could potentially do at the bedside if you have a handheld ultrasound. So the treatment for a post-renal injury is just to relieve the obstruction, and so whether that's with a urinary catheter for a bladder outlet obstruction, or sometimes if they have pretty significant ureteral obstruction, you have to put in percutaneous nephrostomy tubes. So these are actually tubes that you're inserting under by interventional radiology directly into the renal pelvis to drain the urine. And those are temporary tubes until you can deal with whatever's causing the obstruction. And at this point, you're talking with urology. Sometimes they have to go in and get some stones out or something like that, or put some stents in. So let's talk about some of the complications of acute kidney injury. So kidneys are responsible for regulating your acid-base homeostasis and secreting excess acids. And so, if your kidneys are injured and they can't do that, you might have an accumulation of acid in the blood, which can cause a lot of problems. Hyperkalemia is another big complication you worry about. The kidneys are responsible for regulating electrolytes and excreting excess potassium, and so if kidneys aren't working, the potassium might build up, and that can cause life-threatening complications, especially with the heart. If your kidneys can't get rid of urine, can't get rid of the water that's coming in, then you're going to quickly develop fluid overload, and that can lead to pulmonary edema and respiratory failure. And then the kidneys are also responsible for excreting toxins, like, for example, urea. And the accumulation of toxins can cause a variety of different symptoms, ranging from fatigue and weakness to confusion, seizures, and coma. You also can see pericarditis from uremia, and so the patient might have friction rub and chest pain. And then uremia can classically cause asterixis, which is a type of involuntary tremor. It's a specific type of myoclonus that you also see with cirrhosis. But if you see this exam finding in someone with an elevated BUN, that's concerning for uremia. So for a treatment of acute kidney injury, you want to treat the underlying problem. So if they have congestive heart failure, you might need to improve their cardiac output. You might need to diurese them. If they're just really dry, they might just need a bunch of IV fluids. And then, if it progresses like you have an acute tubular injury, then you really just want to focus on supportive care, maintaining their fluid and electrolyte balance, adjusting medications that are renally cleared. And then if you have to do it, then you start them on dialysis to replace their kidneys while you wait to see if the kidneys are going to recover. So when do we pull the trigger on dialysis? Well, there's a helpful mnemonic to remember this, the AEIOU. So A is for acid. So if the patient's pH is below 7.2, despite the best medical management, then that would be an indication to start dialysis. For E, it's electrolytes, which is mostly just related to potassium. If your potassium gets over 6, or you're seeing EKG changes like peak to T waves, that's someone who you want to temporize with medications, but you want to start them on dialysis as soon as possible. And then I is for intoxication. So there are different poisons that patients might take accidentally or not accidentally, and some of them can be removed with dialysis, and so this would be like a more unique indication to do dialysis. But if someone drinks a bunch of antifreeze, you can dialyze that off. If they overdose on lithium, you can dialyze that off. If you accidentally give them too much vancomycin for their infection and cause an acute kidney injury, and now the vancomycin is rapidly accumulating, you can dialyze that off. And then O is for overload. So this is describing, if you get fluid overload leading to pulmonary edema and respiratory failure. So, you might see that they're on 1 or 2 liters of oxygen, but now they're on 6 liters of oxygen, and you're worried that you're going to have to intubate the patient because they're having difficulty oxygenating. Then that's someone that you would want to dialyze. And then U is for uremia. And this is a clinical diagnosis, so we don't have like a specific BUN cutoff. It's not like, okay, once their BUN is over 80, we're going to start dialysis. It's really based on the patient's symptoms. And so if they're having uremic symptoms like nausea, vomiting, or coma, or just confusion with some myoclonic jerks, or maybe they've got a pericardial friction rub and some chest pain, once they have uremia, you definitely want to start dialysis. All right, well, in conclusion, we talked about definitions of acute kidney injury. You should know that, a rising creatinine of 0.3 milligrams per deciliter would be an acute kidney injury. We broadly categorize them into pre-renal, intrarenal, and post-renal injuries. You can use urine studies like urine osms and urine sodium to help classify patients and also predict their response to treatment. A patient with a fractional excretion of sodium less than 1% is going to respond to fluids, whereas if the fractional excretion of sodium is already over 2%, they probably have an acute tubular injury, and giving them more fluids probably isn't going to help. Urinalysis and urine microscopy are very useful for identifying things like dysmorphic red cells, red cell casts, proteinuria, things that could be life-threatening causes of kidney injury. And then severe acute kidney injury can lead to pretty bad complications and may require dialysis. All right, thanks for your attention.